Good day, and welcome to this second in our series of videos from the Practice Protection Committee on maximizing reimbursement under the current environment. I'm Pat Bailey, Medical Director for Advocacy in the DC office, and I'm pleased today to welcome Dr. Charles Mabry from Pine Bluff, Arkansas, a fellow Arkansan who is going to be speaking to us today on coding tips and tricks. Charlie, thanks so much for being with us. We look forward to hear what you have to say.
Well, thanks, Pat. I appreciate that. I want to try to go to the slides now. Well, welcome, everybody. I appreciate your listening to the video. I hope this helps. I think it will. What we're going to cover today is several different topics. We'll just give you an overview first, and then we'll kind of dig into the details. First, I'd like to discuss a little bit about the types of CPT codes and the global period. What does that mean and which codes fit where? And then we're going to focus most of the whole talk on reducing denials, or if it's not denied, getting paid fairly for properly using the modifiers. And we're going to cover different modifiers for surgical codes, modifiers for the E&M services with the global codes, and then a few little tips and tricks about dictation and typed editions for your typical op reports or notes. I think will be very helpful. And then lastly, is kind of late breaking news starting in January 2021, we have a new coding paradigm for documentation for office and outpatient codes. So I want to go over that. And then at the very end, we're going to give you some links to the ACS website, which is just chock full of these very items that you can go back over in detail. Now, let's talk a little bit about the types of CPT codes. In general, there are two, although there are many minor little types, most of the time we deal with either XXX codes or global period codes. Now, XXX codes examples are E&M codes, outpatient procedures, radiology and diagnostic studies, and those can be used multiple times for a same patient at the same time in the same day. There's no global period for that, and each XXX code stands on itself. It has a little bit of pre-service work in there, the face-to-face or service time, and then post-service work. Now, global period codes, which are typically our surgical codes, are really kind of completely different in that they're designed to stand alone by themselves and typically are not used with E&M codes at the same time. Now, if you do use multiple global codes together, then there are modifiers to tell us how to use those, and also modifiers of how to use E&M services during the global period. Now, the global period is important for surgeons to understand is really composed of either a 0-day global, 10-day, or 90-day global. Now, sometimes you'll see these abbreviated as a 000, a 010, and 090 days. And so I want you to be familiar with how sometimes you'll see that in some of the insurance reimbursement, documentation, etc. The components of a global code really include a pre-op visit or a preoperative work involved, intraoperative time, either that's face-to-face from skin time cut to close, and then the post-operative period. And depending on the time, 0-day, 10-day, 90 days, the post-op period will, of course, extend out for 89 days for a global 90-day code and 9 days for a 10-day global, and just that day of the procedure for a 0-day global. Because that covers a lot of time span, it's really important to understand how to use modifiers for either additional surgery or for E&M services so that you're going to get paid appropriately. Now, in general, these are the modifiers you're going to most typically use for global surgery codes. There's other modifiers, but these are the most typical ones. And I usually divide those into the groups of the 20 series codes or modifiers, the 50 series modifiers, and the 70 series modifiers. Okay, so what are those used for? Well, the 22 modifier is used to describe that let's say a laparoscopic cholecystectomy is unusually difficult and requires more than the typical work and time. Now, I hear oftentimes surgeons say that never gets reimbursed. Actually, it is being paid. Other surgeons are getting paid. You should not use the 22 modifier more than around 10-15% of all your procedures. But in general, if you use it and document it well, you should be getting paid more. Typically, the reimbursement through Medicare is around 125% of the base value. Commercial payers sometimes pay more. And so it's important to use this whenever you think it is appropriate, and just document in your op report why this is such a complex procedure. If you can do a gallbladder in 22 minutes and you think that's complex, that you're going the wrong direction. Think of things that add an hour or so to a procedure that normally takes an hour, or 2 hours to a procedure that normally takes 4 hours. That gets you in the right range of trying to describe to someone else why that was a difficult procedure. The 50 series codes are used to describe multiple procedures done typically at the same time or in a follow-up period. So 5.1, the -5.1, is used for multiple procedures. So for instance, if you do let's make this up, let's do a resection of part of the wall of a bladder, and then you also do a colon resection for colon cancer, then those are two separate procedures, but you can use those together if you use a 5.1 on the other procedure. Now, in the CPT code book, you'll have to pay attention because there are some procedures, splenectomy comes to mind, that has splenectomy parentheses, separate procedure, close parentheses. Now, you can still do multiple procedures with that, but you have to realize that the separate procedure will create an edit, and that's where the 5.9 procedure comes in. The 5.9 modifier procedure comes in. It's a separate site, different times, or if you're using a code such as splenectomy that has a separate procedure parentheses in it, use a 5.9 modifier. For all others that don't have the separate procedure parentheses on them, it's fine to use the 5.1 if you do multiple procedures. Now, in this day and time, for trauma particularly, but also for other intra-abdominal emergencies, it's not unusual for us to do a procedure, put in an Abther or some other device, and then take the patient back for a washout procedure a few days later. And that's an example of a staged or a planned take-back procedure. Another example would be doing a skin graft, delay the skin graft, and then apply the skin graft at a later time, or a flap rotation, where you're creating the flap, laying it back down its bed, and then later taking the patient back to surgery and then swinging that flap around. Those are all procedures that you know when you close the skin, you're going to take that patient back. A trauma lap, where you explore the patient, put in lap pads, and then you take them back to take out the lap pads after hemostasis has been obtained, is another great example of a staged procedure. Now, why is that important? The answer is that normally a take back for complications is reduced by 50%. A planned stage take back, the 58, is not reduced at all. And you can also describe that as under 78 if it is an unplanned return. So if you do a procedure, there's an abscess that has to be drained or an anastomosis that's come apart. That's a complication. It's unplanned. You don't plan to have the anastomosis come apart. And so when you take the patient back to surgery, use a 78 modifier, particularly if you're going to repeat the same procedure. And that will keep the claim from being denied, but they will reduce your value by 50%. Now, the common question is from surgeons, why 50%? The answer is that the global period for 90-day code, about half the value sits in the intra-op portion, and the other half the value accounts for the pre-op and post-op care of the patient. And so if they're already paying you for the pre and post-op care for one procedure, they don't want to pay you for the pre and post-op care for the second procedure that's unplanned. So that's included in the first procedure. Now, if you have to take the patient back for a second procedure and you're the physician that does it, then use a 76. Examples of that would be where you do an endoscopy and then have to later on that day repeat the endoscopy to check on something. That would be an example of a repeat procedure in the same time, in the same global period. If another physician does it, then it's a 77 modifier, and that avoids the second physician getting penalized with a 50% reduction. And then finally, the 79 is used by an unrelated procedure by the same physician in the global period. So for instance, if you do a colon resection and then in that global period, insert a Mediport for the patient at a later time, that's an unrelated procedure by the same physician, but in the global period of the colon resection. So be sure to use the 79 modifier to avoid denials. Now, downcoding happens oftentimes when a reviewer, usually at some insurance company or your institution sometimes, will say that they don't really think that you coded correctly, or the code that was applied to your operation or clinic note was not appropriate. To avoid that, there are several things you can do. There's a thing called a CCI edit, Concurrent Coding Initiative. The Concurrent Coding Initiative prevents payment. This is a payment modifier or payment gap measure. So for instance, if you operate and take out a right colon cancer, typically we would take the appendix with it. And when you do your anastomosis, you sew the small bowel to the, for instance, the transverse colon. So if you bill for a right colon resection and anastomosis, you can also bill for an appendectomy. That would be, payment for that would be prevented by a CCI edit. But there are many times that it's appropriate to use two different operations at the same time. You have to ask your coding team if there is a denial, was it a CCI edit, and then read that actual edit. It's a very complex, but you can avoid denial by using the proper modifier with the second procedure that was denied if it was denied by CC edit, and that's the modifiers we just covered. The other thing I think is very helpful is when you're dictating or typing your op report, there's no rule that says you can't put in to that op report your actual CPT code. And so particularly if it's the complex operation, get out the CPT code book, and yes, it will not hurt you to look in there. There's no teeth in there. It's okay. It won't hurt you. Look in there, read the CPT code book about the different procedures you're doing, and then actually dictate that into your op report. That's the best way to prevent denials, because that way the coder at your institution will see what you've coded it. The insurance company that may try to deny that will see what you coded, and they'll understand better how you put together this complex group of procedures that sometimes occurs for surgeons that we have to do. And it also helps you by going back and forth to the CPT code book over a period of time. You're actually going to learn the proper CPT terminology, and there's little notes in the CPT code book that will actually help you avoid denial by reading those little notes. It says, do not code with, and it'll tell you what not to code with, or use this code with these codes. And that gets you a whole leg ahead of avoiding denials by actually reading the book. Your worst fears are confirmed. It's in the book. Now there's another group of modifiers, though, that deals with a patient in the global period that you have to give or attend to, give an E&M code service to. And there's different modifiers depending on which the parent code is. So for a 10-day global after the first day and a 90-day global after the operation, you use a 2-4 modifier. So for instance, if you have a patient that says, let's say has a bad urinary tract infection and comes back to your office and you have to treat them for that, then it's perfectly appropriate for you to charge an E&M bill for that encounter by using a 2-4 modifier applied to the E&M code. Let's say a 99214, you apply the 2-4 to that along with your bill that you send in for the, let's say, colon resection. Now, if it's a 0 or a 10-day global, and this is done on the day of the procedure, you have to use a 2-5 modifier. Now, don't ask me why, that's just the rules. The 2-5 modifier says on the day of the procedure, there's a separately identifiable E&M service that's not included in the E&M service payment that's inside the 0 or 10-day global. Most 0 and 10-day globals include some type of evaluation and management just to get the patient ready for the procedure. So if there's something different apart from that, then append the 2-5 modifier to your E&M code. And then finally, the decision to operate applies to a 90-day global. So if you see someone in the emergency room, now they have to have a lap appendectomy, you code for your either consult or admission to the hospital, and then you apply the 57 to that E&M code, and then take them to surgery and take out your appendix. If you're making the decision to operate for a 0 or 10-day global, then that's where you use the 25 modifier. Now, the other thing to reduce your denials is just like you're including the CPT codes into the surgery op report, I really advise you to include the dictation in any E&M note on why that's not included in the surgical global. It doesn't have to be a very long explanation, but a good explanation would be very helpful. So let's take, for example, of a patient that's had a colon resection And then they have a prolonged ileus, and you're fiddling with them. They may have an NG tube down. You have to look at electrolytes and et cetera. So that's more than the usual typical post-op course. And because of that, every day you see the patient in the hospital, or let's say in your office, you can apply a E&M code to that patient and with a 2-4 modifier, because that's not the typical post-op course. And when you do so, the level of E&M coding depends on what type of decision making and other things that go into the E&M bracket. But apply the 2-4 modifier to that. In your note, I think it's always good to divide your note into a post-op course. So let's say we're seeing a patient in the office where I dictate or type in their usual post-op course, they're doing fine, et cetera. And then a new paragraph would appear. And the patient today has a new onset of a urinary tract infection. And we have to take care of that. We're going to prescribe so-and-so antibiotics. By using a separate paragraph or a separate area of your dictation that alerts the coder that's going to review your code at some point in time, that really was a different diagnosis and a different procedure. And particularly if you append the different diagnosis to the E&M code, in this case, it would be, let's say, a 44140 for the colon resection, and on that same bill would be a 99214-24 modifier with a diagnosis code of urinary tract infection. Since urinary tract infections are not typically seen in a post-op course, that would justify you seeing the patient and treating them. Now, let's go now swing around to what's going to come up in the future. As we all are aware, for the last many years, E&M codes have had kind of a pattern that which you have to use for documentation guidelines. The E&M codes originally came about in 1992, and then in 95 and 97, the documentation guidelines came out to help insurance companies and physicians know how to best code and document what you did to justify the level of coding. And there's bullets, as we all know, there's bullets for the chief complaint, the past history, the present history, the review of systems. If they've been out in the Alaskan wild and been bitten by a moose or something, who knows? But there's bullets for all of that. Under the new guidelines, starting in January, we're going to have different documentation guidelines for the office and outpatient coding. Now, all the other codes, hospitals, ED, nursing home, those E&M codes, those changes will be coming down the pipeline. The college is very involved in developing new documentation guidelines for those codes, but they won't be active in January 2021. What we're going to talk about now is the January 2021 guidelines for office and outpatient billing. And that's really a good move to reduce the documentation and administrative burden. Now let's go back to the bullets for a second. These are the typical notes you see in the charts. EMRs have made this even worse, but it's just blah, 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 most of which time you don't really read most of those little notes. You go to the very end to see what the physician or surgeon said was wrong with the patient, what they need to do. For upper level coding, people have even gone to doing blah, blah, blah for the book level, and it's just pages of stuff. So this is what caused the new guidelines to come into effect. Well, what do those look like? Well, basically the history and physical exam, the bullets have gone away. They're all disappeared. The little bullet fairy came in and took them away. You just need to document what's medically appropriate for that patient, for that level of problem in the history and exam. So you don't have to include all the other organ systems and everything else if that's not appropriate for how you make the diagnosis or how you're going to treat the patient. And then medical decision making. Only those two elements really count now: medically appropriate H&P, and then medical decision making. Now there's another way to code for these, and that's the total time on the day of encounter. I typically don't think that's very applicable to surgeons because we can qualify for higher level coding based on the level of medical decision making that we typically make. So while we have references to this, I'm not going to talk about that today. Lastly, there's been changes for the office and outpatient codes. 99201 has been deleted, and so that no longer will be there. And the established patient 99211 is now really typically reserved for nursing encounters, low-level medical decision-making without a physician being there. So really it now cuts down to just 8 codes we have to worry about. Now, the bulk of the level decision making, of which level you charge, then revolves around three elements: the number and type of problems addressed, the amount and complexity of the data that is reviewed and analyzed, and the third most important thing is the amount of risk that your decision implies or imparts upon the patient. So the more risky the decision, and this can include a decision for a comfort care, decision to stop CPR, things of that sort, those are afforded the highest level of risk. And unlike the old guidelines that required these three elements, all three of them, for medical decision making for new patients, now you only need two of the three for either new or established patients. Now, this is a lot to absorb, but help is out there. This is the link to the Advocacy Division page, and on that page, under Practice Management, there's a whole ton of articles. Dr. Hoyt has often said that the best place to hide something is publish it in the bulletin. And indeed, that's the case. These are all articles that have been published in the bulletin. And when I point them out to surgeons, they're astounded that we've actually written these things and they're out there, but they really are. So I urge you to go to the practice management section of the advocacy page of the college. And then all this information is there. The new E&M coding guidelines, there's a great book that you can download. It's a 15-page PDF. It's very short, sweet. It goes through all these changes in detail. And I think you'll find it's very well done and very well worth your time to read it. And then also there's other things on the practice management side that tell you about office management, practice management, coding courses, the physicians as assistant report, the ACS coding hotline, et cetera. These are all excellent things to look at, but please take the time to go through the college website and look at those, because it really will pay you. You'll actually earn more dollars or more RVUs by knowing these items out there on our website. And lastly, the Practice Protection Committee that's sponsoring this and hosting this webinar, there's a great website there with a resource library. So that pretty well concludes our talk today. And I'll turn it back over to Pat. As always, if you have questions, feel free to email me, and I'll be glad to answer any questions or other items that I can try to help you with.
Well, Charlie, thank you very much for sharing this very practical yet technical advice that's so important for surgeons today to get this right so that they can indeed maximize their reimbursement for the hard work that they do. I just had a couple of questions for you. You went through many of these global surgery modifiers, and which one do you think that surgeons most often miss, or which one or two do they most often miss?
I think the most common mistake in use of modifiers is ignoring the fact that you need a modifier if you're taking a patient back to surgery in the global period. And oftentimes the insurance company will just downcode that as a take back, when really it's a separate procedure. It's a planned take back. And so you're giving up half the value of a big code right off the bat doing that.
And with these new changes that are going to be coming into place in the next 2 to 3 weeks in January with the new E&M guidelines, what things are you most concerned about with this new system that people might get tripped up on?
I think what I hear from surgeons around the country when we go around and give these talks and meet with surgeons is they're afraid of overcoding. And as it turns out, this is not dermatology. We're making big decisions every day on 1,000 patients, and it's all for big risk. I mean, when you take a patient to surgery under anesthesia, everybody's concerned because they may die. And so therefore it's important to understand and give yourself credit for all the risk that you're imparting on the patient when you do that. And so therefore, if you do an appropriate history and physical exam, and then you document the level of risk in medical decision making that you're doing, there's no reason not to code at the upper levels. I mean, it clearly is, we're delivering the value. I think the major mistake that surgeons make is they don't claim the value that they've created.
Right. Well, Charlie, again, thank you so very much for sharing your expertise and your time with us today. And I would just encourage everyone to go to the college's website because there is a wealth of information there. And as we go into this second surge of the virus, the Practice Protection Committee continues to monitor things from the federal government in terms of aid, as well as to provide you with advice to help all of you weather this storm and come out on the other side. So we will look forward to seeing you again for our next production in this series on maximizing reimbursement. Thank you and happy holidays.